Good evening, everyone, and welcome to Black Health Matters Neph Cure Session number 2. I am Dr. Stacey Johnson, and I will be your moderator tonight. I am a registered nurse with 25 years of nursing with a multifaceted skill set and experience in clinical areas ranging from acute care, community care, and executive administration. I am the Senior Clinical Strategic Nurse Consultant at CareSpark Consulting Incorporated. I am the chair of the board at the Institute for Health and Social Equity Incorporated, a 501c3 designated organization whose mission is to reduce healthcare disparities by improving the health and social equities of vulnerable populations and underrepresented groups. I am also an active and proud member of the Westchester County Alumni Chapter of Delta Sigma Theta Sorority Incorporated. I am also the Northeast Region Assistant Director of Chi Eta Phi Sorority, a nursing professional organization. And last but not least, I am a member of the Southeastern Virginia Chapter of the National Black Nurses Association. We want to say thank you. Thank you to NephCure and to Black Health Matters for organizing this event and inviting us here today for this very important talk on kidney disease in our community. NephCure Kidney International is a patient advocacy group that works not only to accelerate research for better treatment for people with kidney disease, but it also provides education and support to patients and caregivers who are affected by these kidney diseases. Black Health Matters works to provide information about health and well-being from a service-oriented perspective with lots of upbeat, positive solutions and tips for the Black community. And this is what we're going to do tonight. On behalf of NephCure and Black Health Matters, we want to especially thank the North Central Providence of Kappa Alpha Psi fraternity for the support and sharing our message with the broader community in tonight's event. Tonight, we are here to bring light to chronic kidney disease and to address numerous of issues related to kidney disease in the Black community. We welcome your questions tonight, and we want you to feel comfortable and engaged with us to have these real talks. Before I introduce our speakers tonight, I would like to first share with you some statistics. Did you know Blacks of African descent in America suffer from kidney failure 3 times more than white Americans? As well, Black Americans constitute for more than 35% of patients in the United States receiving dialysis for kidney failure, but only represent 13.2% of the overall United States population. Our goals tonight is to educate you on chronic kidney disease, specifically a rare form of chronic kidney disease, as we will identify as the abbreviation FSGS. We also want to enforce and educate you on the importance of finding expert care with a nephrologist to take care of your kidneys. We have a lot to talk about, so let me start with introducing our speakers. First, we have Dr. Michael Itomi. He has completed his medical school in Nigeria, Africa, and then obtained his master's in public health. He also did his preventative medicine residency at Yale University School of Medicine in New Haven, Connecticut. He did his internal medicine residency at Columbia Presbyterian Harlem Hospital in New York City, and his nephrology fellowship at Mount Sinai Hospital, as well in New York City. His nephrology fellowship is a wonderful experience that he will definitely expound upon. He is a board-certified internist and a nephrologist. He is also a fellow of the American Society of Nephrology. He is currently a senior partner at Metrolina Nephrology Associates in Charlotte, North Carolina, and he has 25 years of practice covering kidney disease and hypertension. He is also also the official nephrologist of the NBA Charlotte Hornets. Next, we have Mrs. Bernadine Watson. She is our FSGS patient. Dean, as she would like to be called, is a writer and a poet who lives in Washington, D.C. with her husband, Joe. She was diagnosed with FSGS in 1984. Dean has 2 kidney transplants and spent 5 years on dialysis. Her social policy writing has been published in the Washington Post, and her poetry has appeared in the Beltway Poetry Quarterly. Dean reads her poetry throughout the Washington, D.C. region, and she is currently working on her memoir about her experience living with FSGS. So let us embrace Dean, as I'm going to let her open this session with her telling her story. Because storytelling is an important way to learn from others, and maybe someone here tonight may relate to her story and be motivated to call their doctor for a closer look at their health. With that being said, Dean, I'll let you take it from here.
Thank you, Dr. Johnson. As Dr. Stacey Johnson just told you, I was diagnosed with FSGS in 1984 when I was 33 years old. I'll be 70 in July, so that tells you how long I have been living with this disease. I had no symptoms of this kidney disease. I just felt a little fatigued. And in an examination by my gynecologist, she took a urinalysis and found protein in my urine. She told me that this could be a sign of kidney disease, but I really did not believe I had anything like that. But she said I should see a nephrologist, so I did. I went to a nephrologist. I was living in Minneapolis at the time. He did blood and urine tests, and also a biopsy of my kidney because he confirmed that there was protein in my urine. The biopsy came back and he told me I had FSGS. I'm going to attempt to pronounce it. Focal segmental glomerular sclerosis. Dr. Itomi will say it correctly. And I didn't believe him. So living in Minnesota, I went to the Mayo Clinic to have a second opinion. At the Mayo Clinic, they confirmed that diagnosis, but told me that the amount of protein I had in my urine and my creatinine level were both still very low. And they said, the doctor told me that I would probably never get to full kidney failure. And he said, you have a great prognosis. So this was in 1984, for the next decade, I lived my life and everything seemed fine. But around I moved back to Philadelphia, and in about 1995, I remember I had an examination by my doctor, and not a nephrologist, just my regular doctor who would check my kidney function every year or so. And I'll never forget his words. He said, Miss Watson, your creatinine level is ticking up. He sent me to see a nephrologist. And between 1995 and 1999, the nephrologist did everything they could with blood pressure medications, because my blood pressure, which had always been fine, had started to rise with the diminishing of my kidney function. So he tried all kinds of combinations of blood pressure medications, because there really wasn't a lot that could be done for FSGS at the time. And I'm not sure how much more can be done now. But he tried everything with medications. And but by 1999, he told me that by the end of 99, he told me I was either going to have a transplant or go on dialysis. I was on dialysis from January through March of 2000. And in 2000, I had my first kidney transplant. It was a beautiful gift from my sister. It was done at the University of Pennsylvania Hospital. And they told us that my sister was a perfect blood and tissue match, and I should have that kidney for 20 years. Well, the kidney lasted for about 4 years, and the FSGS returned. FSGS apparently is a virulent disease, and I understand that I'm lucky it didn't come back before 4 years. But in 4 years, I had been living my life. I got married. I moved to Washington, D.C., and I was a newlywed, not first time newlywed, but a newlywed. And I had full-blown kidney failure again and was rushed to Washington Hospital Center. That was in December, right before Christmas in 2004. And the next week, I was on dialysis. I stayed on dialysis for 5 years. At first, I got on all the transplant lists, but then my doctor told me that there was a new program of incompatible kidney transplants that was happening at Johns Hopkins. And I began to go up to Hopkins, and in 2009, I had my second transplant. I was a part of a chain. My husband was a part of it. He gave a kidney so that I could get a kidney from an altruistic donor. And that was in September of 2009. And I have been well, generally speaking. And I've had this kidney for 11 years. I'm also good friends with my altruistic donor, but, it was just a fabulous thing that happened for me. So that's my story.
Dean, thank you so much. That is a wonderful story and just heart warmth and just full with just love and care. Thank you. Thank you. I'm sure the audience is very appreciative of you sharing your story. So now we're going to get into our questions. Are we ready? So Dr. Itomi, if you don't mind, can you please share with the audience a general understanding of what is kidney disease?
Thank you, Stacey, and I want to extend gratitude to NephCure and especially Christine Hood for getting me involved. It's always been my passion to work and share knowledge about kidney disease, especially to a minority community, considering the fact that this is a silent disease. And just like hypertension is a silent killer, kidney disease is such silent that you can hear from what Dean had said, that you know nothing about it until you're just hit with a bombshell. You're ready to go on dialysis. So what I'll try to do tonight is to try to enlighten you about what the kidneys do, because you have to first of all understand what they do. When you understand what they do, then it will be easier for you to now follow the disease process that I'm going to explain with specific reference to what Dean has said. And Dean, thank you very much for sharing your story. I can tell you that the last time I spoke to a church of over 2,000 people I took a patient of mine who I had followed from her diagnosis till she was transplanted. So, and I felt it was much more a powerful message for her to be with me on the stage as we made the discussion. I made her do the talking, and then I filled in the other stuff. And that was what very, very well received. And a lot of, especially the Black community, appreciated the fact that this is really closer to home than they think. So let me tell you what the kidneys are. I don't know if you can see your screen, but I just brought this to show that the kidney looks like a beans. So it's shaped like a beans. And what I tell people is, if you make your fists, that's the size of your kidney. And then if you put your hand at your rib cage, behind your rib cage where your thumbs are, that's where the kidneys are. And we're born with 2 kidneys. Now, even though we're born with 2 kidneys, some people actually could be born with 1 kidney, but you don't know. So we technically need only 1 kidney to live. And sometimes I get this question from some patients: if we have 2 kidneys, and if we can live only on one, so why did God give us 2 kidneys? Then what we say is give so that you can donate one. So just to let you understand, so what do these kidneys do? You just have to first of all understand. So I'm going to tell you something else now different. And what I'm going to show you is just looking up here, seeing the 2 kidneys, and on one side of the screen, you see the blue, you see the red tubes, as I'll call them. The red tubes is the artery, and that takes blood and supplies to the kidneys. Now you can see the big portion of where everything here is. That's where all the filters are. So the red tube, the artery takes the blood into the kidneys, and then the kidneys filters purify the blood. After they purify the blood, the good blood returns blue back to the body, and then we pee out the junk through the tube at the bottom, called the ureters. So blood in, cleaned by the filters, return blood good, and then we pee out all the rest. So now let me use some specific terms now to make it a lot easier. These filters that we have, God gives us about 1 million plus or minus tiny little filters in those kidneys that I showed you, each of them. Like eggs in the ovaries of a woman, we are born with the finite number of filters we need for life. So we don't make new filters. So you just have to understand that. So as we all get older, just like women lose their eggs in the ovaries, we begin to drop off some of these filters. But it's not a problem. We have enough till we all die on earth. So what determines the number of filters we have at birth? That's a different conversation, but all has to do with how well you live, your nutritional status, your mom, everything all plays into what you are endowed with until we all die. So what happens is that these filters will continue to function. What do? They do 6 major things in the body. First of all, they purify the blood. What does that mean? Which means that the body makes junk, we eat junk. We just take in there, but the kidney just takes, the filters go in there, purify what it wants, and then just remove what it doesn't need. Then 2, it will balance the chemicals. What does it mean? It means that all the salt, the potassium, the magnesium, all the different things we eat, the kidney just takes what it needs, very sensitive filter, and then just remove what it doesn't need. So that's balancing. Then fluid, it will balance the fluid. You drink a lot, you pee a lot. You drink a little bit, you kind of hold on to it. So these are normal functions of the kidneys. So I can tell you that when things begin to get abnormal, these functions begin to change. Then we call these ones the cleaning function of the kidneys. Then the kidney has 3 hormone functions. The one that we all know the most is the blood pressure. Blood pressure is controlled from the kidneys. And then anemia. What keeps us from getting anemia, called erythropoietin, I'm sure Dean will have had all that word throughout. It's really the hormone that makes red blood cells. It's made in the kidneys. And then finally, the bone strength. So all the parathyroid hormone, the calciums and all that, they're all also done in the kidney. It's the kidney that senses calcium and phosphorus in the blood to make sure that the bones stay healthy. So very complicated function in a complicated organ. And despite these complicated functions, it is extremely silent. So we always advise all our patients, get routine tests. So what are the routine tests that we ask them to do when you go see your doctor? They do them routinely, but I tell my patients, ask questions. It's not enough to say, oh, your kidneys are fine, oh, your urine is clear. No, ask questions, get specific numbers. So I will go to what you should be looking for. Since I mentioned to you that the cleaning and all the junk we make, the one thing that comes to mind, Dean used the word creatinine. And remember that word creatinine. Now, a lot of young folks take creatine powder to try and beef up their muscles. So there's a relationship between creatinine and the muscles. Creatinine is actually found in the muscles. And when the muscles are renewing, the kidneys remove the creatinine from the blood. And if the kidney is functioning perfectly the way it's supposed to function, if we check your creatinine in the blood, it should be 1 or less. Simple numbers to remember, 1 or less. Women have less muscles than men. So a creatinine for a woman that's normal should always be less than 1. For men, 1 plus should be okay or less. Of course, if you're a very muscular man, a linebacker, if you're a Joe Frazier, a Evander Holyfield, any of these big-time boxers with so much muscle, a creatinine of 2 could be perfectly normal because they have heavy muscles. But if I see a creatinine of 2 in a woman, I'll panic. So think about the word creatinine. Now, the next thing you want to look about is the urine, because that's finally where almost all the function of the kidney takes place. It makes you make urine. So when the doctor checks your urine, there's certain things we should not see in the urine. We shouldn't see blood. We shouldn't see protein. What does that mean? Sometimes we say protein is good. I'm going to be talking about good protein. I'm not going to talk about bad protein. But just remember, anytime the kidney is filtering, it keeps what the body wants. The body wants the protein, albumin. It keeps it in. It can't let it go. And then it keeps the red cells in. It can't let them go. So your urine should not contain protein or red cells. So when you see protein or red cells in the urine, that's a sign that something's going on in the filter. Then I give this analogy. If you want to brew coffee and you put the coffee filter and you put the coffee grains in the filter, when you brew the coffee and you look at the coffee pot, you're not supposed to see grains, are you? No. If you see grains, what does it tell you? The filter is leaking. So the more grains you see, the worse the filter is. It does not tell you what has caused the filter to leak, but it just tells you the filter is leaking. So seeing protein in the urine, or what we call proteinuria, is a sign of kidney disease. Seeing blood in the urine, which we call hematuria, is a sign of kidney disease. Very, very silent things that you will never ever know. Then when you come to the hormone side, it's your blood pressure that tends to give away kidney disease. Like she said, I always had normal blood pressure all my life. Then all of a sudden, your blood pressure goes up. So hypertension is something that should always make you check whether your kidneys are fine. Because you have hypertension doesn't mean you have kidney disease. But if you have kidney disease, you have to make sure you don't have hypertension, but you are likely to also have hypertension. So this is kind of a snapshot of what the normal kidneys do. So from this, I'll stop here, then I'll eventually, no, let me continue because it will make more sense. So if this kidney is functioning normally the way it's designed to do, then what are the causes? What will make the kidneys fail? Why? Why should the kidneys fail? I can tell you that in African Americans and most people, Native Americans, as well as Hispanics and some whites, diabetes and hypertension are the 2 greatest reasons most of our patients are on dialysis. So if you have diabetes, you have hypertension, you have an obligation to make sure they're not beginning to mess up your kidney. Not everyone with diabetes or hypertension will develop kidney disease, but you have a good chance that you need to be monitored very closely. So diabetes, hypertension up there. Then the next thing is the immune system. The immune system, it's like our soldiers. They protect us. They do anything we want to do. We don't die when we catch a cold. It's not all the antibiotics we get. It's really the immune system. But sometimes the immune system gets perverted and attacks the body. And when it attacks the body and attacks those kidney filters, it can damage them. So in young people, lupus is the number one reason why you have immune system disease. Now that there are so many other immune system diseases, and FSGS, focal segmental glomerulosclerosis, falls in that category. And this is also unique because focal segmental glomerulosclerosis also has some genetic link as well. So you have immune system and some genetic diseases that can cause kidney failure. Then medications. Virtually everything dumps into the kidneys. And as nephrologists or kidney specialists, we sometimes act as detectives, because when we see kidney disease happens, we begin to rack through everything that has happened to the patient. We ask all sorts of history, including pain medications, especially the ones we call the non-steroidal anti-inflammatory drugs, the ibuprofens, the Motrins, the Aleve, Advils. Those medications can cause kidney disease, especially if you're prone to kidney disease and you don't know, if you are dehydrated, or you are taking other medications with which they can interact. Some antibiotics can do the same thing. Viruses, HIV, can cause kidney disease, amongst other viruses. And as we now know, coronavirus also takes the kidney out. So this kidney is subject to so many different things that happen. So when we see something, we're kind of scanning through the whole virtual medical system to see what has happened. In many instances, we're able to do something and reverse them. In other instances, we can't do anything but slow the progression. Having said that, I'm going to share one final thing with you before we go into specifics. What are the stages of chronic kidney disease? So when we've not talked about all this and you tell somebody they have chronic kidney disease, what does it mean? For simplicity of definition, in medicine, we define something as chronic if it's there 3 months or longer. So if I check your protein, your creatinine levels, and I can go back to your records, see they've been there for some time, then we brand it chronic. Because sometimes you can dehydrate, your creatinine goes up, but you rehydrate, it comes down. So we have to see that chronicity. So when you say you have chronic kidney disease, it's divided into 5 stages. And I want you all to remember very, very clearly, I'm going to deliberately go through the stages. Stage 1, the kidney. First of all, let me just make it clear that when I say creatinine of 1 is normal or less, just assume your kidney is closer to 100%. So when I have stage 1 chronic kidney disease, it means the creatinine is about, the percentage of kidney is about 90% working. Stage 2 is between 60 and 89%. Stage 3 is now 30 to 59. Stage 4 drops further down to 15 to 29. Stage 5 is less than 15. That is when all that conversation about dialysis and transplantation takes place. Stage 1 and stage 2 are so silent that even regular medical doctors don't even see it. So they don't even send them to us as kidney specialists. We don't want them because the numbers are overwhelming. Over 850 million people are in the world with chronic kidney disease. In the US, huge numbers, so you can't even handle them. So we begin to see patients stage 3, which is between 30 and 59. There's stage 3A, stage 3B, but let's not complicate that, but 30 to 59. So most patients with chronic kidney disease will fall into stage 1 and stage 3. So we see the stage 3, and what we try to do at that point is to do interventions that can slow the progress to stage 4 and to stage 5. These interventions could be blood pressure control, diabetes control, avoiding medications that can create all these problems, and sometimes kidney biopsy, especially if we can't explain readily why you have the kidney disease. And when you do the kidney biopsy, it will show you certain lesions that can help us guide us to decide what you have. In the specific instance of focal segmental glomerulosclerosis, think again about that coffee filter. If you open your coffee filter and you see scarred points, you know, it doesn't tell you what are scarred them, but you know they're scars. That is what focal segmental glomerulosclerosis is. You see the scars, it doesn't tell you what has caused the scars. Most of the reasons are all over the map. So many diseases can cause the FSGS. But the one she's talking about, we call it idiopathic, nobody knows why, or primary. So you have FSGS that is primary and FSGS that is secondary to diabetes, to infections, to HIV, to immune system, to different things. But this other one is idiopathic or primary, you don't know the reason. And in the particular instance of FSGS and African descent, there's something called the apolipoprotein.
Dr. Cobb's work. Yeah.
Is the alpha lipoprotein 1.
Yeah.
These are actually mutations that occur on about 6 genes on chromosome 22. These specific mutations of the lipoproteins, alpha lipoprotein 1 and 2, are only seen exclusively in people with African descent. The story is that perhaps it's kind of an adaptation against trypanosomes, filarias and all that, but somehow winds up affecting those filters in the kidneys. So this genetic disease can actually be, I wouldn't like to use the word transmitted, but it actually can be transferred from one patient to the other. Like she got it from her sister, even though she got, I mean, like her factor got into her sister's kidney. She had what we call the permeability factor that affected her sister's kidney. So it's in there, so it can be genetic. So we are actually asking these days for genetic testing, if it is possible, for virtually all Black patients who want to donate kidneys, because you like to know whether they have the gene. It doesn't mean that the gene is always bad, doesn't mean that, but you want to know. If you have 2 mutations, it's bad news, because 2 mutations almost guarantee you're going to have kidney disease. So if you have 1 mutation, so genetic testing is something we're beginning to preach a lot to our Black brothers and sisters, not to run away from, you know, considering the fact that we've all been burned by history and all sorts of different tests that have made us so shy away from the medical profession. But we want you to trust us to let you know what is good in certain instances that you should be part of. So this focal segmental glomerulosclerosis, it's one of the reasons for kidney failure. It's not as huge as diabetes and it's not as huge as hypertension, but it's closely related to hypertension. Very closely related to hypertension. I have had patients where 3, 4 brothers all have the same disease, FSGS. And 3, 4 dialysis transplants, some passed away, but I still have one I've been following for 20-something years. What she told you now, if you go back to her history, it took her 15 years from when she was first told you have protein in the urine till she got her transplant, from 1984 to 1999. She is one of the luckier ones. If you have double mutation of that gene, you don't last that long. We're talking about 4 or 5 years from when it happens, and your age tends to be younger when it happens. But when we see these diseases, we then try to intervene to slow the progression. If you control somebody's blood pressure, you will increase the life of the kidney. If the blood pressure is not controlled, he goes rapidly down to dialysis. So we then talk about that. We talk about diet. We talk about different things, lifestyle modification that can just help the kidneys function the best. So that's where we are, and I'll take questions as they arise.
Well, thank you, Dr. Itomi, for that robust explanation of what kidney disease is, also symptoms that we should be aware of, some risk factors, as well as discussing screening diagnostic procedures that could help us better understand when we are at risk or when we're having symptoms, because this is a silent disease. And we do have multiple questions that we need to address. So I'm going to ask this question for Dean. So Dean, as an African American, we all know that there are disparities in our community, and access to healthcare, and even to the point of diagnostic, being able to give the opportunity to have diagnostic procedures or diagnostic testing even discussed with us. Can you please elaborate on any screening programs that you've encountered in your journey available for kidney disease?
By screening programs, I'm not sure what you mean. Do you mean, I know when I got your analysis, is that considered a screening program?
So one of the questions that we received is, are there screening programs available for kidney disease?
Let me help her real quick. I think what Stacey's or the question is it not necessarily, yeah, when you go to your doctor, you get routine cleaning tests, but is there any other program out there that goes around trying to screen people for kidney disease? Yes, the National Kidney Foundation, especially in many different local chapters, carry out screening tests along with some other societies. The National Kidney Foundation is definitely big on screening specifically for kidney disease.
But do you think, Dr. Itomi, that most people, African Americans in American communities, know about this screening and have access to it? Because I did not. No, and I'm a middle class person.
And you are right about that. And I think that is part of what I think NEFCure tries to do. I used to be on the board of the North Carolina National Kidney Foundation. We try to go in there to educate people. And you're right, the education is less than optimal. There's so much room to improve, and we have to utilize everything that we can. We have spoken to churches, we try to get priests involved. I have some priests who have been my patients and are strong advocates and try to get me to talk, but there has to be something bigger than that. Partly, if you hear something like cystic fibrosis, everybody knows about cystic fibrosis, but for Christ's sake, that disease is so minuscule in terms of how it occurs, but the whole idea is that it's so out there because there's a lot of so much foundation supporting it. So kidney disease has not really received the same screening, has not received the same type of educational things, and I think this should hopefully turn around as we go ahead.
Now, as we know, kidney disease is seen as taboo in the Black community. A lot of individuals who are suffering with kidney, they keep it a secret because no one is supposed to know, or they want to avoid dialysis. I've experienced many patients where it's like, I don't want to go on dialysis because I remember when grandma would come home looking tired, looking beat, quality of life looks as though it's affected in a negative light when it comes to kidney disease. Do you have any strategies or any type of suggestions or recommendations to how we can engage our community and understanding that kidney disease, dealing with it, seeking treatment, going through with the interventions, that it's okay and not taboo?
That question is very, very true. And I can tell you that as a nephrologist, when we go to do consultations on patients, the worst the patients ever want to hear, even if you tell them they've had a heart attack that's threatening their life in the immediate, they're not worried about it. The moment you mention kidney failure dialysis, the depression kicks in, and then the denial takes place. And because it's a silent organ, it doesn't wake you up to go do anything. By the time you begin to develop swollen feet, feeling tired, fatigued, you're ready for dialysis, more or less. So it's a silent thing. It's not like asthma. You can't breathe, you're wheezing, you go to the hospital. You know, you have abdominal pain for something, you go find out you have ulcer, you have chest pain, you run to the hospital. Kidney disease does not give you any of those warning signs. So it's such an emotional disease, if I want to use that word, that patients really get depressed about it. Now, in the US, remember I told you diabetes and hypertension, especially diabetes, are the number one reason people go on dialysis. So dialysis itself is not really the problem. Sometimes, really, it's the underlying disease. Diabetes eats up the body, so to speak, and grinds you down. Diabetes will cause you to go blind. It will affect your blood vessels, your artery, your everything, your heart. So a lot of times when you see patients feeling sick and tired post dialysis, it's because so many other things are going on with them. It's all a convergence of all these different things that are happening in the patients. So the memories you tend to have will be, and then also in the US, we dialyze almost everybody. In most European countries, they don't dialyze people above a certain age group. Some don't even dialyze diabetics. So we dialyze everyone. So what you remember is that older patients that are developing kidney disease, they have diabetes, they have heart disease, they're on dialysis, everything's going bad. You take them up for dialysis, they're weak, they're tired on a wheelchair. It's a stress on the family, financially, emotionally, physically. So it's kind of a big stress on everyone. So that image is what people kind of sets people away. I can tell you on the flip side, we have so many young people who do dialysis at home. You know, whether it's peritoneal dialysis or home dialysis, you don't even see them. They're around. They may even be in our audience. That's what we want to achieve. We want to get people home, independent, go to work. You know, don't do all those other things. So you're right about that. And why should the Black community, I mean, some in the Black community deny it? You know, we need to do more work on the education.
Yeah, I wanted to just talk a little bit about being on dialysis, because I was in my early 50s when I went on dialysis. I was healthy. I did not have diabetes. I did not have high blood pressure even. As you said, my FSGS was idiopathic. Nobody could tell where it came from. But what I found is that nobody helped me. The medical system did not help me deal with the psychological aspects of being on dialysis. Nobody, said to me, a lot of people are on dialysis and it's maintenance. They don't intend to get a transplant. They intend to be on dialysis. It becomes like a part of their life. They come and they eat with their friends. And so it was how to stay alive and live well on dialysis for as long as you need to be on it was not really, it was nothing that was stressed. And I think that was part of it. It wasn't stressed. This is a lifesaver. 25 years ago, you would have been dead. So let's see what we can do while you're on dialysis to keep you healthy, to keep you upbeat, to keep you, I had to try to seek counseling and do yoga and all that stuff on my own so that I could survive and have a decent quality of life until I could, find a kidney and get a transplant.
So what I'm hearing is that as healthcare providers and practitioners, we need to be very instrumental in ensuring that our patients are receiving the mental health piece and the component when related to kidney disease, that there is an emotional piece to this, that there is a need for us to ensure that our patients are receiving that mental health service that they need. And also for patients who are dealing with it personally, it's okay for them to seek the mental health intervention so that they can have an easier not seamless, but an easier transition with accepting this disease and also accepting the treatment and the maintenance.
Yeah, I mean, and then I'll be quiet. But can you imagine, and this might be too much information, but can you imagine that you have a disease where you can no longer urinate? Mentally, psychologically, what does that mean? Do I smell? Do I want people to know this?
Wow.
Is all of this urine in me and all parts of my body? I mean, it's a real issue.
Yes.
I had to figure out ways of dealing with all of those things in order to motivate myself to try to be healthy and to go on with my life.
Well, we have a few questions, and we do have approximately 15 more minutes to our show. I'm going to start with a question. It stated, in 2020, my creatinine level from a blood test was 1.34. My doctor said I should not be concerned, even after an ultrasound of my kidney. Should I see a nephrologist?
The thing is that you don't take the creatinine level in isolation. First of all, you have to do you have high blood pressure? Do you have any risk factors? Do you have high blood pressure? Do you have diabetes? Was your urine normal? Was there blood or protein, anything else in the urine? You know, if all those other ones, the answer to those questions are all and entirely no. So what we try to do is to repeat your creatinine again. And then finally, if a man or a woman, if it's a woman, 1.34 is definitely not normal. But if everything else is checked out, that is no high blood pressure, no diabetes, no protein, everything, and it's there, you've got an ultrasound, they've done all the tests for immune system diseases and viruses, I normally will say see a nephrologist at least for one visit for a woman, so that they're better positioned to just clear the coast for you and say, hold on, we've done everything fine, just check it every 6 months or check it every year. And if it balances out, then just do your routine. If it's a man and he's a muscular guy, nothing else going on, that could be normal for him.
Thank you. Next question. How do we get our physician to treat your rare condition, specifically C3G?
The complement 3 glomerulonephritis is an extremely rare disease with different manifestations, and usually you do the diagnosis with a biopsy along with so many of the other serological tests that you do. Depending on that, this particular treatment is related to your nephrologist. It's your nephrologist that will decide whether it needs to be monitored or it needs to be aggressively treated, depending on all the other manifestations that go with it.
Thank you. Can you please explain to us why EGFR for Blacks is calculated differently for other communities?
Eventually, we're probably going to be moving away from that. What they mean by the EGFR is estimated glomerular filtration rate. Glomerular filtration rate is just telling us, equilibrated glomerular filtration is just telling us about the function or the percentage of the kidneys that work. So when I'm telling you 60 to 90% and all that, you can break down that into millimeters per minute. Just that's what it tells us. But because there are many things that are taken into that calculation, and they take sex, race, body weights, and one more thing into the calculation. And then they now decide that for African Americans, there seems, because of either muscle mass or rare genetic reasons, their estimated GFR tend to be higher compared to other people. But I can tell you that newer tests are coming out that's going to eliminate this potential confusion that's taking place. So when you see the blood test that comes in, if they tell you African American creatinine is 2, the EFGFR is 50. Then if you're non-African American, it says that same thing is 35. So kind of two different connotations as it goes along. But just remember that all these are estimates with so many different factors taken into the calculation.
Well, coming to the diagnosis arena, GFR, do you believe that that's an effective way of diagnosing rare kidney disease or kidney disease in general?
No. GFR, again, glomerular filtration rates, we try to tie that to creatinine. Creatinine is not a perfect marker of kidney disease, neither is the GFR. We just give you some estimates to work with. I can have somebody with a creatinine of 2 and his GFR could be 50. I can have somebody with creatinine of 2, the GFR could be 30. So you cannot make a firm diagnosis in that sense. You take everything holistically in terms of diabetes, high blood pressure, hypertension, protein. You lump them all in to now make sense of that diagnosis. Unfortunately, this is what we have. It comes on over and over again with life insurance. When life insurance wants to do, they just pick up some GFR from the computer that reads it, and then they just brand you chronic kidney disease. It's unfortunate when it happens, and sometimes we've been forced to do biopsy on some patients just to say, hey, they don't have it. Even though their quote-unquote EGFR is 60, it's still normal for them. Everything is relative. So just kind of put that in perspective. As you get older, your GFR drops. Why? I told you, we all lose kidney filters as we get older. So at age 70, 80, I mean, the GFR at 70, 80 is definitely going to be less than when you were 30 or 40 years old. So all those have to be taken into consideration. Like I said, all these are the factors that are going into calculating EGFR. Unfortunately, it's not the best way to say somebody has kidney disease or not.
So we have another question. Can you briefly explain the link between kidney disease and genetics?
Now, there are so many genes that cause diseases. It's not just only kidney diseases. Breast cancer, we know about that. We know liver disease. There's so many different genes that can cause kidney diseases. In the particular case of the genetics with kidney disease, especially in children, there are many different genes that are called different types of kidney disease. And sometimes they just manifest as protein in the urine first. So when you do all the biopsies, you will not necessarily, you will find out what the lesion is, but may not really find out what it is until you do specific genetic testing. And so in the particular case of FSGS, I've told you those genes are in the alpha lipoprotein 1, and they mutate. So there is definitely a link between kidney disease and genetics and kidney disease, but not a bread and butter what we all know. Those ones are really rare. The most common genetic cause of kidney disease is autosomal dominant polycystic kidney disease. So that's the number one genetic disease that causes kidney failure.
This question is for Dean. As a patient seeking care for kidney disease and for diagnostic intervention purposes, did you find that having certain insurances were a barrier? Do you have any input in regards to which insurances that you may be aware of that cover dialysis or any type of kidney care services?
One of the things I can tell you, unfortunately, as physicians, is that we're all too technical and scientific in what we do, that we sometimes don't realize that there are other extraneous factors that can affect how well the patient gets the service that we want them to recommend. So we can write all these things you want to write, and then the patient either doesn't have insurance or the insurance doesn't cover as much. Unfortunately, we don't know which is which. A lot of the front staff and specific people in the finance office might be able to find out. And I wish we could do and know more about that, because some patients are unable to get the type of testing they need to get the diagnosis they do need in good time for you to intervene. I wish we could do, we knew that, but we don't. Not all the time.
Oh, well, thank you. Maybe Dean, you could probably help explain or share your experience as a patient seeking health care.
I can share some of my experience. I was fortunate enough to have private insurance and have had private insurance throughout. I'm on Medicare now, but what I found was that when I had, it seemed that when I had private insurance and I was on dialysis, I was I'll just say, I was in dialysis with people who had Medicaid, and there seemed to be more limitations on the things that they had access to. I had more access to different kinds of specialists, to different kinds of tests, to getting on this kidney lists for transplant. And I even was told at one time I was an attractive transplant patient because I had private insurance. Mm-hmm. And so, and the doctors encouraged me to get on the transplant list, and they paid a lot more attention to me, it seemed, that because I had private insurance, and I also had a lot of sort of family support. And because, there were a lot of class issues, it seemed to me, around issues of insurance and the kind of family support you had, and the kind of attention that I got as a medical patient. So I think that there definitely are issues there when it comes to the kind of insurance you have and the kind of treatment you get.
So that sounds like, Dean, we need to put your writing skills, your policy writing skills to work, and head over to the Capitol and get some of these policies changed in regards to the CMS with the Medicare and Medicaid population.
Let me just throw a little light with specific to the transplant issue she just mentioned. The transplant is extremely expensive. It's upward north of $150,000. And in certain programs as high as $300,000. So you can see there and then that not everybody will be in the right mix to be able to afford that kind of money for transplant. Now, if you have Medicare, Medicaid, or private insurances, yes, your private insurances are more likely to cover, but this is what happens with specific instance with transplant. Medicare, Medicaid are government insurances, fabulous because they give you lots of coverage. But even though they give you lots of coverage, they also limit what can be done and how much is placed on them. Medicaid, usually for states and people who are disabled or indigent. Medicare for older people who are then also people who are disabled. So there's a limit to which they can do. On Medicare, they'll cap you to what you can be paid. Mm-hmm. But when it comes to transplant, they will pay for your transplant, true, but after 3 years on transplant, they won't pay for the transplant medications. Mm-hmm. And we've have patients who've lost their kidneys when their Medicare have dropped. It's kind of, it's outrageous. Yeah. So there are new bills and working going on where I think more recently now they're about to pass a bill that will cover everybody now. Where we've had patients who've lost their kidneys because they could no longer afford their transplant medications. So go ahead. Yeah, go ahead.
I had people, patients who are in dialysis with me who would not go for a transplant because they knew that after 3 years, they would lose the support, the insurance that they had, the money for getting for getting their medication, and also
disability too.
Disability money. People, were not necessarily going to have a lot of success in the job market. So for them, they were on dialysis, and it was a way of life because they had very few options simply because they were poor.
Correct.
This is why this discussion is so important, and it's so vital that we in positions of power and practitioners and practice and skill settings and different acute settings and community settings, that we really hear this and that we take action to really speak up and advocate for our patients. And I really appreciate, and I'm sure the audience appreciates, everything that's been shared this evening. We are coming to an end. It is almost 8 p.m. We have 2 more questions that we can possibly answer quickly. The last 2 questions are, is it possible to present with proteinuria, but have normal levels of creatinine in the blood?
Absolutely, yes. The answer is yes. You can leak your proteins and then your creatinine doesn't go up. So correct, yes.
And the last question is, are liver disease and kidney disease related?
They are not quite cousins in that sense, but if you have liver disease, it will eventually affect your kidneys, and we call it hepatorenal syndrome. And there are some rare conditions where the liver and kidneys may be there, but they are not always related. So if somebody has kidney disease, they don't have to have liver disease. If they have liver disease, they don't have to have kidney disease. But if you have instances, somebody's an alcoholic, they've knocked out their liver, they developed all the ascites and different things can eventually affect how the kidney works.
Well, again, thank you so much, Dr. Itomi. Thank you so much, Dean, for your wealth of knowledge, your passion, giving us your story. It's just been a fabulous evening. And I think that I can speak on the behalf of the audience because they're giving us great comments that they've enjoyed your presentation. And again, thank you for talking about what matters in our Black communities, Black and Brown communities, and giving us this information.
Stacey, if I may
Yes.
add one thing real quickly.
Sure.
In this era of COVID, one of the things we are finding out, especially in our Black communities, is that we're doing a lot of telehealth. And in doing telehealth, we are beginning to find out a lot of our minority patients don't know how to don't either have the video, don't know how to use the video, they're either alone. So they're not really getting the best of care through telehealth the way it is. So that's kind of a new barrier, to good health care. So for everyone in the audience, one thing that we can actually do, we can improve telehealth capability in our community. We should go for it. Make sure everybody's able to get that, because telehealth has come to stay. Even if COVID is under control, telehealth is not going anywhere. So that's a big thing in our community.
Well, bittersweet, but we're going to say goodnight. And again, thank you, Dr. Itomi, and thank you, Dean. Thank you, audience. Thank you. Without you, this wouldn't happen. So thank you for participating. Thank you for listening. Thank you for tuning in. And again, thank Black Health Matters, thank NephCure International, and the Kappas fraternity for allowing us to have this moment to embrace knowledge and collaborate and support our communities. Have a wonderful night, everyone.
Thank you. Thanks. Bye, everyone. Okay.
Bye-bye.